So the basics of radiotherapy. So radiation is basically two forms. We have electromagnetic radiation in the form of photons or X-rays. So makes up the majority of therapeutic radiation used within radiation oncology. And then there's particulate radiation, electrons and protons, and electrons have been around for a long time but don't have much use in the treatment of brain tumor, but protons certainly are finding more application. The effect of radiation in all instances is through ionization, and in the case of photons, this is an indirect effect by liberating electrons, secondary electrons, which then produce the ionization in tissues, whereas the particulate radiations produce ionization directly because they're charged particles. And through ionization, you're depositing energy into tissue, and in depositing this energy, you affect chemical changes which have the desired effect on the tumor. So in terms of what the basic radiobiology of radiation therapy is, well, we have physical ionization either directly through a charged particle or indirectly through free radicals generated by ionization of water, basically, affecting really the target molecule that we think is in play is the DNA itself. And by inducing strand breaks within the DNA, we're able to induce errors in the irreparable errors, primarily through the production of double strand breaks, which then form a lethal lesion and leads to the death of a cell during replication. And on the bottom here, you can see immunohistochemistry staining showing DNA damage produced by high linear transfer particles, this sort of linear tracking through the nucleus of a cell. So what happens when cells die? Well, then you have either your desired effect on the tumor by killing off tumor cells, but you can also cause damage within normal tissues and consequential effects on normal tissues. And we try to limit those adverse effects through a number of means, through the shaping of the beam, through fractionation, which exploits differences in tumor and normal tissues and their ability to repair radiation injury. The other effect we'll talk a little bit about is the potential for carcinogenesis associated with radiation. If we think about clinically, how does radiation manifest itself when we are treating our patient, we tend to divide the effects of radiotherapy into the acute, subacute, and late effects of radiation. And so when an individual is, for instance, starting a course of fractionated radiotherapy, one can see the side effects or the effects listed here. Early on in treatment, one might notice symptoms of worsened radiation edema, and this is due to immediate effects on the blood-brain barrier, and you can induce increased leakiness early on in the course of radiotherapy. So during the first week of radiation, one might see worsening neurologic symptoms or headache associated with that edema. A common question that comes up is should all patients be started on steroids prophylactically before cranial radiation? And my practice is just to maintain steroids if they're in play, but if patients are not already on steroids, I usually just monitor them closely during that first week and institute them as necessary. The nausea and vomiting is often seen with radiation of the posterior fossa, and the other side effects listed tend to manifest later in the course of radiotherapy as radiation affects some of the epithelial tissues. The mechanism of fatigue is not really well understood, but certainly fatigue is a common side effect of radiation noted during the weeks of radiotherapy. In the subacute phase, which is a month and a half to 3 months post-radiation, one can see a return of fatigue and sometimes an associated decline in neurologic function, and it's thought that this represents a transient demyelination effect that manifests at this point. This is also the point where one can see pseudoprogression showing up on imaging, and so it's important under these circumstances to try and put the clinical and radiographic picture together to decide, are you looking at early tumor progression versus subacute radiation effects. and it may be possible to use functional forms of imaging such as PET or MR spectroscopy, but often the most practical thing to do is perhaps institute some steroids or increase their steroids and re-image them in a month or so. And if it is a radiation effect, that should resolve over that time, and if it's a tumor, that will become evident as well. In terms of late effects, we tend to think of the neurocognitive and sequelae of treatment, but also there's the potential for radiation necrosis. In terms of neurocognitive effects, this is really a function of the volume of brain being irradiated and also affected by the dose, total dose and the dose per fraction. There are all sorts of confounders that can contribute to neurocognitive problems, particularly the use of anticonvulsants and other intracranial insults that can happen in the course of brain tumor treatment, the use of concurrent chemotherapy, etc. Management of neurocognitive problems is still in evolution, but there have been reports of some pharmacologic interventions that may be helpful, and they are listed there. Radiation necrosis, again, related in this time more to the total dose of radiation, but also dose per fraction. And an example is shown above, and again may mimic tumor progression. Metabolic or metabolic imaging may help discern this, or debulking or surgical sampling. So depending on the severity of the necrosis, individuals may be managed just with steroids and observation, or surgical resection. And as we may hear about later, Avastin seems to be coming to the fore as an effective treatment for symptomatic radiation necrosis. And then just briefly, there is the potential for radiation to be associated with an increased risk of second malignancies, and this is seen most prominently in the pediatric population. In the Children Cancer Study group have a large cohort of children followed for decades who had cranial radiation, and what they have seen is an excess risk of both glioma and meningioma, with a steeper dose response for meningioma than glioma, and so the dose response here for glioma versus meningioma, but also different pattern of occurrence where gliomas tend to show up a little bit earlier on in the first decade or two, where meningiomas show up more in the second, third decade and longer. And this is an MRI of an individual who was irradiated as an infant at about 24 months, and grew up and has been working productively as a security guard, but unfortunately has now developed multiple meningiomas, and this represents a bit of a therapeutic challenge, and it certainly fits with what the this cohort has noted about children irradiated in infancy or in younger years. So on to the indications. Well, we'll hear about both benign and malignant tumors. In terms of benign tumors, radiation may play a role for tumors that are unresectable, such as this cavernous sinus meningioma, or recurrent, such as this recurrent convexity meningioma, which is an atypical meningioma, and also the management of malignant brain tumors, where the risk of recurrence with surgery alone is significant. Just a word about the past, and it's not that long ago that we were planning radiotherapy based on basically fluoroscopic images and trying to relate cross-sectional imaging to fluoroscopic plane views of the skull, and trying to map out simple radiation fields like a rectangle here. And while you probably wouldn't miss tumors, or I don't think we miss tumors all that often, you probably irradiated more brain than you needed to. So here's an example of a lateralized tumor treated with a parallel pair. So there's a whole lot of brain on the opposite side that you really couldn't spare effectively with these simple techniques. I think where our technology has helped us a lot is in terms of minimizing the dose to uninvolved brain and being able to conform our dose more precisely to the tumor itself. So now we have sophisticated linear accelerators. So here's a linear accelerator with a treatment couch. It has the radiation beam would emanate from this part of the machine. There is an electronic portal imaging device that allows you to image the beam directly, but there's also a kilovoltage X-ray imaging source here that allows you to get fluoroscopic quality images, but you can also rotate this whole thing 360 degrees and get cross-sectional imaging with cone beam CT scans. These machines have multi-leaf collimators, which can shape the beam and also move dynamically during beam on to produce a variable beam intensity, and this is located up in the head of the machine. And so contemporary radiation, I mean, this is a fairly simple plan, but just putting in a beam from the side and a beam from the top, and now you can produce a more focal irradiation of a lateralized brain tumor. And contemporary radiation will typically bring into play many radiation beams to optimize the ability to shape the beam from many directions. So we have 4 basic steps as we plan and deliver our radiation treatment. So there's a planning stage where we're acquiring diagnostic and planning scans. There is a segmentation phase where we're segmenting out the target or the tumor and critical organs we want to avoid. The planning phase where we're designing our beam arrangement and calculating dose, and then delivering the radiation. So for treatment planning, we include a form of immobilization. This is probably the simplest form of immobilization, which is a thermoplastic shell. You can see that there is immobilization under the chin and the shoulders, and this is important. It takes the head tilt out. There is a setup mark here that is aligned to lasers in the room to allow precision localization each day, which can also be coupled with in-room imaging to refine the positioning of the patient. And these devices are custom fabricated for each individual, and this is done prior to acquiring a volumetric CT scan, which basically gives us the 3-dimensional imaging that we need and electron density information that we need to segment out and calculate dose for treatment planning. We have the ability to electronically fuse the diagnostic MRI with the planning CT so that we can delineate the tumor, in this case a low-grade glioma, on the modality that we can see it best on, which is usually the MR, but then have those contours transferred in a stereotactic fiducial manner onto the planning CT to facilitate our treatment planning. And an innovation that many places are exploring is the use of MR simulation. So this is a case where we were able to, we've adapted the MR scanner with a flat couch insert and custom head coils so that the patient can be scanned in the MRI scanner with their mobilization mask. And these are MR and CT compatible fiducials here. And if this works, you can see that there is good alignment between the MR and the CT. And so that provides an extra level of confidence in terms of outlining on the MR and ensuring that your registration is accurate. And this is, again, a case of a recurrent meningioma. So in terms of segmentation, you may hear radiation oncologists talk about acronyms like the GTV, the CTV, and these are fairly standard nomenclature for contemporary radiation planning. So GTV refers to gross tumor volume, CTV is the clinical tumor volume, OAR is organ at risk, and planning target volume is the PTV. So gross tumor volume is that tumor which is imageable on CT or MRI. CTV is the surrounding brain that is felt to be at risk. And PTV is a margin that is placed around those other volumes to account for variability and setup day to day. And the organs at risk are those critical structures that you want to avoid. So we can, in this instance, we have a pituitary region tumor that's been segmented out, and organs at risk, including the eyes, the lens, optic nerves, hippocampal region, brainstem. So you develop a full 3-dimensional view of what the target and the region is at risk are, which then leads you into treatment planning. And in this case, we have a fairly straightforward 3D conformal plan where we have beams coming in from through the forehead and angled back from the sides. And one can see a beam aperture here that is designed to match with the planning target volume. And this is just a display of all the beams overlapping. And then you can calculate in an axial plane, you see the beams overlapping, and where there's full overlap of the beams, you get full dose deposition, and you can calculate dose and see that the full dose is delivered to the central region, and then where beams are exiting and non-overlapping, you get much lower dose. So in this instance, we're giving about 4,500 centigrade to the center, and then this low-dose wash is down at around 100 centigrade, so about just a few percent of the prescription dose. And so the idea, a fairly fundamental principle in radiation oncology, is this idea of accepting larger low-dose volumes in order to concentrate the high-dose volume in a fairly discrete area, and using multiple non-coplanar beam arrangements to achieve that. The difficulty comes in when you've got complex tumor shapes that may be wrapping around a critical organ like the brainstem or the brain, because if you put a single beam in, no matter what direction you choose, you're going to have some shadowing of the normal structures through that beam trajectory. So that's where this technique of intensity modulated radiotherapy comes in, and it really takes the treatment delivery to a new level and doesn't just shape the beam aperture, but shapes the beam fluence or the beam intensity across that aperture. So this sort of schematic shows a gray scale showing that around the edges from a given beam direction, the dose is higher. At the anterior area, the dose is lower. And so, for instance, if you were putting a beam in through this region where you're mainly going through tumor, the intensity may be higher than over on this edge of the beam where you're skimming through normal brain. And then this sort of beam is delivered with the multi-leaf collimator, so you can see the beam apertures here will change dynamically through the course of treatment and deliver a differential amount of radiation to different beam segments, and that gives you the summated dose of an uneven fluence from that direction. And when you add up multiple beams of uneven fluence, then you can get very complex dose distributions. But IMRT is tricky to do, and it relies on computerized planning to determine these beam fluences. And if you do not tell the computer what you want carefully, or you don't monitor the computer carefully, you can end up with sloppy IMRT distributions. So in this case, we've got hot spots outside of the region that we want to treat. The dose doesn't really conform all that well to the tumor. We've got hot spot here, which is right over the optic nerve, so this is not a good plan. But with some refinement and reoptimization, now we've got a plan that conforms better. If there's a hot spot now, it's out over in the skull, and we don't have hot spots in the area of the optic nerve. So IMRT gives you a lot of flexibility in conforming the dose, but requires a lot of attention to make sure you have optimized your plan to your best ability. And you do have choices that you can make. You can, in this display, we have a dose volume histogram. This is the volume of organ being irradiated and dose received. So for your PTV, you really would like to treat 100% of the target to 100% of the dose. So here's a plan that gives a nice uniform dose to the PTV, but perhaps gives the brainstem more dose than you would like. And if you choose, you can re-optimize this to provide more sparing of the brainstem, but at the cost of somewhat less homogeneous irradiation of the PTV. So intensity modulated radiotherapy gives you the opportunity to make these trade-offs in terms of relative coverage of the target versus organ at risk sparing. In terms of treatment delivery, I think if anybody has followed the New York Times in the new year, they may have seen a series of articles relating to some unfortunate radiation accidents related to intensity modulated radiotherapy in the New York region. And this really highlights that this is sophisticated technology that really needs to be deployed carefully. So I think that any center doing this really needs to have a solid quality assurance program in place. So in our institution, we use phantoms. This is a cylindrical phantom that you can put radiographic film in and then irradiate this inanimate object with the beam pattern that you want to treat the patient with. And then you can see that you have reproduced a plan here in the film, and this plan was designed to spare the spinal cord and spare some central structures. This is a head and neck case, so it's sparing the trachea. And then you can compare what the radiographic film recorded versus what you plan to give and see that there's good correspondence between the plan and what you delivered in terms of these peaks and valleys. So this sort of quality assurance is important to have in place, and for intensity modulated radiotherapy, basically every patient should have an in-phantom quality assurance session or measurement before treatment commences. In terms of the treatment itself, standard fractionated radiotherapy is given at a dose of 2 gray per day. what I would call that a fraction, typically over 25 to 30 treatments. So typically 50 to 60 gray, 5,000 to 6,000 centigrade. So again, we can acquire fluoroscopic-like images if we want daily on the treatment unit. We can compare that to digitally reconstructed radiographs from our simulation, and we have overlay tools that allow us to show if these are lining up well and make adjustments on a day-to-day basis by looking at things like the correspondence between the bone tables. So just a simple 2D match using the AP and lateral radiographs can give us good accuracy in alignment day-to-day when combined with that mask-based immobilization. We have newer treatment units that will incorporate image guidance. So this is a tomotherapy unit. So it incorporates a spiral delivery of an intensity modulated fan beam for its delivery, and it incorporates a CT detector array, so you can acquire helical CTs for daily treatment localization. And here's an example of a patient with, in gray, the planning CT, and in the teal color, the megavoltage fan beam CT acquired on the tomotherapy unit. And again, at the interfaces, you can see there's good alignment between the bone table, and there are interactive tools that let you adjust the patient positioning each day. And modern linear accelerators delivering intensity modulated radiotherapy can use cone beam CT to accomplish the same thing. So we basically have two different platforms, common platforms for delivering intensity modulated radiotherapy, and they both can do a good job. I won't talk much about radiosurgery except to say radiosurgery and stereotactic radiotherapy takes all of these principles and just takes it up a notch in terms of the degree of stereotaxis and localization and beam collimation that allows you to be even more focused in your delivery, and allows you to use larger dose per fraction safely by shaping and targeting the beam precisely. So in this case, cerebellopontine angle meningioma, and you can see a very sharp dose gradient being delivered using a non-invasive stereotactic frame with a optical fiducial bite block system. In this case, a CyberKnife system. In this case, a gamma knife treating a residual pituitary adenoma with some distance between the chiasm. So all of these technologies available for radiosurgery, and all characterized by the need to restrict to smaller lesions that are sufficiently away, or at least not invading organs at risk, and typically treating with 1 or maybe up to 5 fractions. So you put this all together, and here's a patient with a chondrosarcoma of the cavernous sinus clivus region that I treated using our tomotherapy. So we used a daily image-guided IMRT to deliver a dose of 76 gray to this lesion, which is proton-level doses, but we were able to accomplish this with our photon machine, and we can see the before and the after, showing an early response of this tumor, and this patient has had durable control, and we were able to establish a very sharp dose gradient with an adjacent organ at risk, the brainstem, and this patient has had no adverse consequences from his treatment. We also now have the flexibility to deliver craniospinal irradiation very efficiently. Tomotherapy is a fairly slick platform for doing that, but any of the image-guided intensity modulated platforms will allow us to do high-quality craniospinal radiation. And we can get even more fancy, and here we have reirradiation of a glioma in the posterior fossa or in the occipital lobe with a hypofractionated technique using daily image guidance. And something here which is interesting, and we're exploring as a research protocol, using a simultaneous boost where one delivers whole brain radiotherapy at traditional 3 gray per day, 30 gray and 10 fractions, but then boosting synchronously the individual metastasis with a higher dose per fraction. And we have a phase 2 protocol taking these individual lesions up to 60 gray and 10 fractions as an alternative to traditional radiosurgery boost. And all of these platforms can let you do this and treat all these lesions synchronously and to different dose levels. So that's an area of interest for the future. In terms of comparing photon beam techniques and protons and such, when you do head-to-head comparisons really what you could find is that all of these platforms give you good conformality to the target. There are some differences in the low dose region, but it's really hard to know whether that is clinically significant, and depends who you're talking to and what tool they have as to how strongly they feel that difference is important or not. And just sort of a little bit of a cautionary note in the back of our minds, we always have this trade-off of a larger low-dose region in order to conform a high-dose region. Well, this low-dose region may be a region at risk for carcinogenesis, and while we may be able to dose escalate our tumors and keep our critical organs down on the dose response curve, we don't really know where this carcinogenesis curve is, and we have a little bit of apprehension about our techniques in this regard, but to date, we've not seen an excess risk of second malignancies as our techniques have become more sophisticated. So just to sum it up, in my opinion, if you've got large tumors that are invading normal brain or embedding or encircling organs at risk, you really need to fractionate, and usually fractionate over weeks, 5 to 6 weeks. Radiosurgery, as we'll likely hear later, is an option for smaller lesions without mass effect or organ at risk involvement. That we have a number of platforms that incorporate image guidance and stereotactic conformal capabilities, and in my opinion, you just know your tool well and know your QA for that tool well, and that's more important than whether you have a tomotherapy machine or a trilogy machine or an artisan machine or whatever. So I think that concludes my my talk, and I would take questions, and I think we have some polling questions too.
Glenn, that was fantastic. Thank you. We're gonna get to the polling questions in just a second. I'd like to take this opportunity to just remind all of our participants today to please use your chat box or your Q&A feature to ask questions to us, and we will make sure that they get answered during this forum and also during the blog at the conclusion of this session tonight for the next several days. We can go to the polling questions in just a moment, but I thought I'd sort of start some questions off, Glenn, for you by just sort of painting a little bit of a clinical scenario. Let's say we're dealing with a patient who already underwent standard radiation therapy after initial surgery for a GBM. They now have a pretty focal recurrence, and the patient's being presented at a weekly tumor board, and your colleagues are asking for your radiation oncology expertise to talk about what, if any, are potential radiation options for this focal recurrence. And I guess specifically, how do you go about choosing between things like fractionated stereotactic radiosurgery, standard radiosurgery, or other forms of radiation? And if you alter the fractionation schedules, can you potentially decrease the risk of radiation necrosis? And I guess, does all of this change if the tumor is particularly large or small or near critical structures? How do you go about framing that set of concerns?
Well, I think basically my practice is I tend to favor a hypofractionated stereotactic radiotherapy approach with image guidance. I tend to use a dose somewhere around 30 to 36 gray and 5 to 6 fractions. There's sort of case literature to support that. There's not a lot of head-to-head comparisons to really say what the toxicity profile is between that sort of approach versus a single fraction radiosurgery approach. My general impression is the rates of necrosis may be maybe a little less, but I think if you have a small lesion that's under 3 to 4 centimeters and it's away from an organ at risk, I think radiosurgery is perfectly acceptable alternative as well. But I think that as you get closer to organs at risk, then fractionation is probably safer, though even a hypofractionated course around, reirradiation around the optic apparatus and such is a little bit dicey. The problem is that conventionally fractionated reirradiation is not all that satisfactory either. So I think in a situation like that, if the tumor was larger and lots of organs at risk in the area, I would probably look into my medical oncology colleagues to try and carry the day. There was one case, there was one question that came up on my chat box. I just thought I might address really quickly about the phantom or the phantom QA. Do we do this for all our IMRT cases? And I would say for all of our CNS cases and all of our head neck cases, absolutely. There are certain instances, say for prostate cancer, where we use IMRT and we have a fairly well-established class solution, and we may not feel a need to do a phantom QA for all of those patients, but anything sort of head and neck or brain, we do that routinely.
Great, perfect. Well, let's go to our first question, and we can present it and have everyone answer. So you see a picture here, and the question is, what type of radiation planning structure is indicated by the arrow? And the choices are as follows: GTV, PTV, CTV, OAR, which is organ at risk, and ETV. So I guess if everyone can take a moment and answer the polling questions to the right of the screen, click your answer, and then hit submit. And we'll wait a few seconds for those poll results to come in, and David will advance the slides when that occurs. But I guess, Glenn, if you could take us through this question at this point and tell us the answer and go through the choices.
Yep, so just as a reminder, so the GTV would have been the imageable tumor, so in this case the tumor in the sella. The PTV is the CTV with a margin for setup uncertainty, so that would be that sort of volume there. And the ETV was my attempt at humor, the eye target volume, but that's not right. Clearly the eye is an organ at risk, or OAR.
Great. So it looks like the correct answer was D, and there we go. The vast majority of people, in fact, everyone who answered got it right. Some people aren't answering. Encourage everyone to answer. It is anonymous, and that's great. Okay, let's go to the second question. So here we're asking everyone to please choose the incorrect statement about this radiation beam display, which is pictured to the left. Again, choose the incorrect statement. So 1, intensely modulated; 2, inversely planned; 3, three-dimensional conformal; 4, requires dynamic collimation; and 5, requires in-phantom QA. Take a moment to answer the question to the right, and please hit submit when you're done.
So it is the incorrect one that we want.
Correct.
So this beam display, if you look at the grayscale, it shows that there's heterogeneity of the grayscale. So this is an intensity modulated beam, which requires inverse treatment planning and requires the dynamic multi-leaf collimation to deliver. And as we discussed, should be associated with in-phantom QA prior to treatment. If this was a three-dimensional conformal beam, what you would see is just the beam aperture with a uniform sort of color wash in the middle, indicating a uniform beam fluence. So the answer in this case is 3. The incorrect answer is three-dimensional conformal. This is not that. This is an intensity modulated beam display. Okay.
So we see from our polling results a little bit of a spread, probably for hearing terms for the first time for many in the neurosurgery world, but that imaging is very helpful.